Once bile is produced by the liver, bile through the bile ducts income to the gallbladder, and gallbladder is the place where bile is stored until we consume some fatty food. Basically, the only function of the gallbladder is to store bile and to reabsorb water from the bile during the storage. So gallbladder makes bile more viscous, and increase in viscosity creates some problems. Let's take for example cholesterol stones. So for example, we have a female patient with obesity that has a lot of children and also she is older than 40. So all these factors increase the amount of cholesterol in the blood and thereby the amount of cholesterol in the bile. And now such bile with very high amount of cholesterol income to the gallbladder. And after water reabsorption, the concentration of cholesterol becomes extremely high. Such state we call hypersaturation with cholesterol, and in this state, gallstones are formed very rapidly. So with time, finally, this causes formation of a cholesterol gallstone, and the presence of gallstone in the gallbladder we call cholelithiasis. And such stones inside the gallbladder remain totally asymptomatic. But after intake of the fatty meal, at some point, large amount of fatty acids income to the duodenum. In response to dietary lipids, eye cells of the duodenum secrete cholecystokinin. Cholecystokinin is a specific hormone that stimulates contractility of the gallbladder. So as a result, gallbladder contracts, and by this, gallbladder pushes bile together with cholesterol stone into the cystic duct. Recall that bile flow from the gallbladder into the common bile duct is equal to pressure inside the gallbladder minus pressure inside the common bile duct divided on resistance between them. So with contraction of the gallbladder, the pressure inside the gallbladder increase, and as a result flow increase. So by contraction, gallbladder pushes bile through the cystic duct into the common bile duct. In ideal scenario, such gallstone freely pass through the cystic duct, then stone pass common bile duct and enters into the duodenum, and from the duodenum such stone is excreted with the feces. But sometimes such stone cannot squeeze through the cystic duct. In this case, stone causes an obturation of the cystic duct, and with obturation of the cystic duct, radius of the cystic duct decrease. With decrease in radius, resistance increase, and with increase in resistance, flow decrease. Basically, with full obturation, there will be no flow of bile through the cystic duct. As we see, the major provoking factor that leads to obturation in the biliary tract is intake of fatty meal, because it's fatty meal-induced contraction of the gallbladder that pushes stone into the biliary ducts. The problem here is that contraction of the fully filled gallbladder against fully obstructed cystic duct creates enormous pressure inside the gallbladder, and such high pressure causes major clinical symptoms. To explain this, here we have a gallbladder. Inside the gallbladder we have intramural blood vessel that delivers blood to the cells in the gallbladder wall, and also gallbladder wall have nerve endings. When stone causes an obstruction, the flow of bile out of the gallbladder becomes disrupted, so bile remains in the gallbladder. As a result, when gallbladder contracts, we have outer force of contraction that acts on gallbladder wall, and also fluid that remains in the gallbladder causes pressure from the inside. As a result, gallbladder wall becomes basically compressed. Such compression, first of all, is sensed by nerve endings that carry the signal to the foregut autonomic nerves, that in response to this becomes activated, and the activation produces an abrupt onset of dull pain in the abdomen, moderate to severe in intensity. Because gallbladder is localized in the right upper quadrant of the abdomen, typically biliary pain starts in the right upper quadrant, and on physical examination with palpation, pain will cause tenderness in the right upper quadrant of the abdomen. Also, dull pain in the right upper quadrant typically associated with nausea and vomiting, and such pain pattern we call biliary pain. With full obstruction of the cystic duct, gallbladder remains fully filled with bile despite numerous contractions, and accumulation of the bile inside the gallbladder cause gallbladder overdistension, and on physical examination we can determine a mass in the right upper quadrant of the abdomen. Because gallbladder remains overdistended, such gallbladder can come in contact with diaphragm, and numerous contractions of overdistended gallbladder can cause irritation of the diaphragm, which is sensed by phrenic nerve. And phrenic nerve carries this impulse to the cervical nerves. And as we know from the cervical nerves also originate supraclavicular nerves that innervate the back of the shoulder. So this pain impulse from the gallbladder ends up in supraclavicular nerves from the right side. And because these nerves innervate back of the shoulder, we sense diaphragm irritation as pain in the back of the shoulder, or it can be just pain in the back. So biliary pain often radiates to the right shoulder or to the back, and paradoxically, biliary pain also manifests as shoulder pain or back pain. But in addition to pain, prolonged obstruction causes prolonged compression, and compression can also affect blood supply. As we know, blood flow is equal to pressure difference divided on resistance, and the resistance is inversely proportional to the force power of radius. So in case of compression, the radius of the blood vessel that provides perfusion of the gallbladder wall decrease. With decrease in radius, resistance increase, and with increase in resistance, flow decrease. As a result, perfusion of the gallbladder wall decrease, and this state we call ischemia. If stone passes, compression resolves, and thereby ischemia resolves, so no further problems. But if obstruction is prolonged, then compression lasts longer, and with prolonged ischemia cells begin to die, and with cellular death neutrophils comes in, so inflammation develops. The more prolonged is the ischemia, the higher amount of cells die, and thereby the more severe becomes inflammation. In addition to this, bacteria from the gallbladder can leak to the site of inflammation, and bacterial invasion only aggravates inflammation. With inflammation, white blood cells increase, mostly due to the increase in neutrophils. Also, erythrocyte sedimentation rate increase and C-reactive protein increase. With inflammation, a lot of inflammatory mediators are released into the blood, including prostaglandins. Prostaglandins stimulate thermoregulatory center of the hypothalamus, and this causes increase in body temperature, so fever and tachycardia develops. With inflammation, permeability of the blood vessels increase. As a result, the walls of the gallbladder become thicker, and also around the gallbladder wall we can observe pericholecystic fluid, which is a key criteria on ultrasound. Also in this image we can see gallstone inside the gallbladder. Prolonged ischemia, especially with bacterial invasion, very rapidly progress and finally affects entire thickness of the gallbladder wall. We call this transmural inflammation. Such severe inflammation of the gallbladder causes irritation of adjacent structures, including peritoneum. And peritoneum has a lot of somatic nerves. So once peritoneum becomes irritated, it causes abdominal pain, and also as a protective mechanism, it causes a muscle spasm in the abdominal wall to protect the site of inflammation from the external pressure. And we can detect this spasm on palpation. We call this abdominal guarding. In addition to this, if we ask patient to make a deep inspiration, with inspiration diaphragm pushes gallbladder downwards, and in this state we can palpate the gallbladder. But because gallbladder walls are inflamed, any palpation in the right upper quadrant will cause pain, and pain with palpation in the right upper quadrant on inspiration we call positive Murphy sign. Also because common bile duct remain open, so bile can freely pass to the duodenum, cholecystitis do not cause cholestasis, so ALT and GGT will be normal, and also there will be no liver injury, so ALT and AST will be also normal. Acute cholecystitis has two potential complications. It's gangrenous cholecystitis and Gallstone Ileus. To explain this, here we have a gallbladder with the stones inside, and one of these stones caused obstruction, and prolonged obstruction cause inflammation of the gallbladder walls, a condition that we call cholecystitis. First of all, with time inflammation can become very severe, and such severe inflammation of the gallbladder walls we call gangrenous cholecystitis. The problem is that inflamed gallbladder walls become so fragile that with time rupture of the gallbladder wall occurs, and in this case gallbladder come in contact with the intestine. Gallbladder wall stick to the intestinal wall, and thereby inflammation also spreads to the intestine. And damage to intestinal wall can cause formation of a fistula between the gallbladder and intestine. As a result, gallbladder content, including stones, pass into the intestine. Then stones move through the small intestine until some big stone reaches ileocecal valve. The problem is that ileocecal valve is the most narrow location in the intestine, and big stone can cause obstruction here, so small bowel obstruction develops. Also, gas in the intestine now can pass into the gallbladder and biliary tree, and the presence of gas in the biliary tree we call pneumobilia, which is definitely pathological state. And the presence of gallstone in the iliac fossa, small bowel obstruction and pneumobilia we know as Rigler triad.